Multiple sclerosis, MS, is a complex disease characterized by inflammation. Although the exact cause of MS is not clear, the pathogenic process occurs in the periphery, outside of the central nervous system, CNS, and frequently in the lymph nodes. B cells are essential for mounting healthy immune responses. They release pro-inflammatory cytokines to protect the body from infection, produce antibodies to capture and eliminate antigens, and present antigens to T cells. When T cells encounter B cells presenting antigen in the lymph node, T cell differentiation and proliferation are triggered. In people with MS, evidence has shown B cells capture autoantigens derived from neurons or their myelin sheaths and present portions of those autoantigens to T cells within the lymph nodes, promoting activation of pathogenic encephalitogenic T cells. In other words, B cells direct T cells to attack the body's CNS tissue. Homing signals, much like a GPS, help these autoreactive B cells and T cells navigate to the CNS, where they drive inflammation. B cells may also produce antibodies that can play a role in disease pathology. As MS progresses, B cells and T cells have been suggested to remain within the CNS and form germinal centers, also denoted as ectopic follicles, in the leptomeninges, the two innermost layers of tissue that cover the brain and spinal cord, to drive further CNS-specific inflammation. The role of B cells in MS pathology makes them targets for treatment. Most B cells express CD20 on their plasma membrane. CD20 is not expressed by plasma cells, which produce protective antibodies needed for healthy immune responses. Ofatumumab is a fully human anti-CD20 monoclonal antibody. It is thought to work by selectively binding to sites on both the small and large extracellular loops of CD20. Ofatumumab causes CD20-positive B cells to be vulnerable to both immediate and delayed B cell lysis by mechanisms such as complement-dependent cytotoxicity, CDC, and antibody-dependent cellular cytotoxicity, ADCC. The binding of ofatumumab is linked primarily to CDC, resulting in formation of membrane attack complexes, MAC, and leading to highly selective destruction of CD20-positive B cells. Evidence suggests B cells that do not express CD20 should be spared, including the plasma cells that provide protective immunity. Lymph nodes are a main site of B cell action. The subcutaneous administration of ofatumumab promotes specific targeting of the lymph nodes. As a result of its subcutaneous administration, preclinical evidence shows that ofatumumab preferentially depletes B cells in the lymph nodes. Consequently, the selective mechanism of action and subcutaneous administration of ofatumumab that promotes depletion of B cells in the lymph nodes may preserve B cells in the spleen. This is hypothesized to help maintain immune function. In summary, B cells play a key role in MS pathogenesis. Targeted depletion of B cells has been shown to suppress inflammatory activity in MS. Ofatumumab is a fully human anti-CD20 monoclonal antibody that induces selective lysis of CD20-positive B cells. Subcutaneous administration of ofatumumab is thought to promote preferential depletion of B cells in the lymph nodes and may spare B cells in the spleen, which are hypothesized to help maintain immune function.
Indication: KESIMPTA is indicated for the treatment of relapsing forms of multiple sclerosis, MS, to include clinically isolated syndrome, relapsing remitting disease, and active secondary progressive disease in adults. Important safety information. Contraindications. KESIMPTA is contraindicated in patients with active hepatitis B virus, HBV, infection, or history of hypersensitivity to ofatumumab, or life-threatening injection-related reaction to KESIMPTA. Hypersensitivity reactions have included anaphylaxis and angioedema. Warnings and precautions. Infections. Serious, including life-threatening or fatal, bacterial, fungal, and new or reactivated viral infections have been observed during and following completion of treatment with anti-CD20 B-cell depleting therapies. The overall rate of infections and serious infections in KESIMPTA-treated patients was similar to teriflunomide-treated patients, 51.6% versus 52.7%, and 2.5% versus 1.8% respectively. The most common infections reported by KESIMPTA-treated patients in relapsing MS, RMS, trials included upper respiratory tract infection 39% and urinary tract infection 10%. Delay KESIMPTA administration in patients with an active infection until resolved. Consider the potential increased immunosuppressive effects when initiating KESIMPTA after an immunosuppressive therapy or initiating an immunosuppressive therapy after KESIMPTA. Hepatitis B virus. Reactivation. No reports of HBV reactivation in patients with MS treated with KESIMPTA. However, HBV reactivation, in some cases resulting in fulminant hepatitis, hepatic failure, and death, has occurred in patients treated with ofatumumab at higher intravenous doses for chronic lymphocytic leukemia, CLL, than the recommended dose in MS and in patients treated with other anti-CD20 antibodies. Infection. KESIMPTA is contraindicated in patients with active hepatitis B disease. Fatal infections caused by HBV in patients who have not been previously infected have occurred in patients treated with ofatumumab at higher intravenous doses for CLL than the recommended dose in MS. Perform HBV screening in all patients before initiation of KESIMPTA. Patients who are negative for HBsAg and positive for HB core antibody, HBcAb+, or are carriers of HBV, HBsAg+, should consult liver disease experts before starting and during KESIMPTA treatment. Progressive multifocal leukoencephalopathy. No cases of progressive multifocal leukoencephalopathy, PML, have been reported for KESIMPTA in RMS clinical studies. However, PML resulting in death has occurred in patients being treated with ofatumumab at higher intravenous doses for CLL than the recommended dose in MS. In addition, JC virus infection resulting in PML has also been observed in patients treated with other anti-CD20 antibodies and other MS therapies. If PML is suspected, withhold KESIMPTA and perform an appropriate diagnostic evaluation. If PML is confirmed, KESIMPTA should be discontinued. Vaccinations. Administer all immunizations according to immunization guidelines. For live or live attenuated vaccines, at least 4 weeks, and whenever possible, at least 2 weeks prior to starting KESIMPTA for inactivated vaccines. The safety of immunization with live or live attenuated vaccines following KESIMPTA therapy has not been studied. Vaccination with live or live attenuated vaccines is not recommended during treatment and after discontinuation until B-cell repletion. Vaccination of infants born to mothers treated with KESIMPTA during pregnancy. For infants whose mother was treated with KESIMPTA during pregnancy, assess B-cell counts prior to administration of live or live attenuated vaccines. If the B-cell count has not recovered in the infant, do not administer the vaccine, as having depleted B-cells may pose an increased risk in these infants. Injection-related reactions and hypersensitivity reactions. KESIMPTA can result in systemic injection-related reactions and hypersensitivity reactions, which may be serious or life-threatening. Injection-related reactions with systemic symptoms occurred most commonly within 24 hours of the first injection, but were also observed with later injections. There were no life-threatening injection reactions in RMS clinical studies. In the post-marketing setting, additional systemic injection-related reactions and hypersensitivity reactions have been reported, including anaphylaxis, angioedema, pruritus, rash, urticaria, erythema, bronchospasm, throat irritation, oropharyngeal pain, dyspnea, pharyngeal or laryngeal edema, flushing, hypotension, dizziness, nausea, and tachycardia. Most cases were not serious and occurred with the first injection. Symptoms of systemic injection-related reactions may be clinically indistinguishable from acute hypersensitivity reactions. The first injection of KESIMPTA should be performed under the guidance of an appropriately trained healthcare professional. If systemic injection-related reactions occur, initiate appropriate therapy. Patients who experience symptoms of systemic injection-related reactions or hypersensitivity reactions with KESIMPTA should be instructed to seek immediate medical attention. If local injection-related reactions occur, symptomatic treatment is recommended. Reduction in immunoglobulins. As expected with any B-cell depleting therapy, decreased immunoglobulin levels were observed. Monitor the levels of quantitative serum immunoglobulins during treatment, especially in patients with opportunistic or recurrent infections and after discontinuation of therapy until B-cell repletion. Consider discontinuing KESIMPTA therapy if a patient with low immunoglobulins develops a serious opportunistic infection or recurrent infections, or if prolonged hypogammaglobulinemia requires treatment with intravenous immunoglobulins. Liver injury. Clinically significant liver injury without findings of viral hepatitis has been reported in the post-marketing setting. Signs of liver injury have occurred weeks to months after administration. Patients treated with KESIMPTA found to have an alanine aminotransferase or aspartate aminotransferase greater than 3 times the upper limit of normal, ULN, with serum total bilirubin greater than 2 times the ULN, are potentially at risk for severe drug-induced liver injury. Obtain liver function tests prior to initiating treatment. Monitor for signs and symptoms of hepatic injury during treatment, including new or worsening fatigue, anorexia, nausea, vomiting, right upper abdominal discomfort, dark urine, or jaundice. If symptoms of liver injury are reported, measure serum aminotransferases, alkaline phosphatase, and bilirubin levels. Discontinue KESIMPTA if liver injury is present and an alternative etiology is not identified. Fetal risk. Based on animal data, KESIMPTA can cause fetal harm due to B-cell lymphopenia and reduce antibody response in offspring exposed to KESIMPTA in utero. Transient peripheral B-cell depletion and lymphocytopenia have been reported in infants born to mothers exposed to other anti-CD20 B-cell depleting antibodies during pregnancy. Advise females of reproductive potential to use effective contraception while receiving KESIMPTA and for at least 6 months after the last dose. Most common adverse reactions. Most common adverse reactions, greater than 10%, are upper respiratory tract infection, headache, injection-related reactions, and local injection site reactions.